All right, everyone, let's get started with this exciting competition. My name is Punar Karajamandic. I'm a professor in the finance department at the Carlson School of Management, and welcome to our third annual interdisciplinary health data competition. Now, let me share my screen a little bit. I'm just going to do a quick welcome and introduce the competition a little bit. All right. All right, so our third annual University of Minnesota Health Data Competition this year, we're hosting it through our brand new Business Advancement Center for Health, BAC. And so every year we have students join in as interdisciplinary teams. We had 75 students join this year. And again, every year we require a data set to be used. In this year's challenge, the data set required was the Hospital Consumer Assessment of Healthcare Providers and Systems, or HCAP survey in short, from the Centers for Medicare and Medicaid Services. HCAPS is a national survey, standardized, publicly reported, and that documents patients' experiences and perspectives in their hospital care. It allows for comparisons across different hospitals, both locally, regionally, as well as nationally, and really captures patient experience on a multitude of dimensions like communications with doctors, cleanliness, quietness, the discharge information, how well their pain was managed, and more than 4,000 hospitals and 3 million patients participate in the survey annually. So this year's challenge was that the teams basically dive into this required data set and they complete an exploratory analysis of the HCAPs, the hospital CAP surveys, to assess how the patient experience relates to other aspects of care. And also the teams were allowed to use any other publicly available data set that could be merged to the HCAPs. I want to thank our judges very much. We had first round judges. I'm going to name them: Matt Chuck from Bind, Alex Everhard from Harvard MIT Center for Regulatory Science, Elaine Hammond from Optum Labs, John Hargraves from Healthcare Coast Institute, Molly Jeffrey from Mayo Clinic, Todd Johnson from Israel Healthcare, Spencer Merchant from United Health Group, Donna Spencer from RTI International, Kurt Waltenbach from Unitas, Michael Weber from Hennepin Healthcare Systems, Audrey Workman from DaVita Kidney Care, and Bill Voivod from Komodo Health. You can see the diversity of our judges. We're just so excited about this, and we thank them very much. And we had our University of Minnesota faculty both participate as a steering committee as well as judge: Robin Alston from School of Nursing, Caitlin Carroll from School of Public Health, Joel Farley from College of Pharmacy, Russell Funk from Carlson School of Management, and Steve Johnson from Institute for Health Informatics. Again, thank you very much. Now, 5 teams were selected as the finalists, and you will hear their presentations very soon. And I would like to now also introduce our final judges who will be judging this very final round. So maybe if I could have each of the judges just say a few words and share some wisdom and encouragement with our presenters just before our competition final start. David Cook is a Senior Vice President from Optum Labs. David, do you want to say a few words?
So first, congratulations to everybody. My background is I'm a physician, previously at Mayo. I was in practice analytics and systems engineering and lead a large research training team in Optum Labs, a central part of which are data scientists. You guys are on the right track choosing this kind of work for your careers.
Thank you, David. Danita Kaiser, VP of Research Partnerships in Optum. Danita?
Hello, everyone. Congratulations to the finalists. It's such a pleasure to be here, and I'm really excited to hear about your projects. I am the Vice President of Research Partnerships for Optum Technology, where I build relationships around the world with academics and academic teams that have commonality with the hope of transforming a lot of healthcare. So I've been with Optum for about almost 7 years now. Most of my work has been in the area of data science, machine learning, big data. I have a long career in products, actually, in technology products, and I have my PhD in computational chemistry from a long time ago, but really thrilled to be here. Thank you for letting me judge.
Thank you, Danita. We have Rich Kruger, Systems Director of Data Technologies and mHealth Fairview.
Good afternoon. Rich Kruger, as mentioned, System Director of Data Technologies with mHealth Fairview. I've been working with data, business intelligence, and data technologies for about 25 years now in a myriad of industries, but most of the last 15 or so in the healthcare industry, and I'm very excited to see what you've put together.
Thank you, Rich. And Mark Veda, who's the chair of the Division of Engineering in Mayo Clinic.
Hi there. Hopefully you can hear me okay.
Yes, we can.
I'm not able to start my video, so I won't. I'll leave that off.
Okay.
Sorry about that. Hi. So Mark Weed, chair of the engineering group at Mayo. We're a in-house development group that focuses on developing new medical devices, primarily in the product discovery space, so innovation and new products. And I'm certainly very excited to be here today. This is my third year judging this competition, and I keep coming back because of the amazing presentations from the teams. And this one is a particular interest to me because at Mayo we recognize that the patient experience is central to the care that we provide for the patients. It's part of holistically providing the best care possible to the patients, and we know that a good patient experience is reflected in better outcomes. So very excited to see what the teams have been able to come up with.
Thank you so much, Mark. Thank you. And yes, thank you for judging many years and hopefully more. And same goes to all our judges. So thank you to our judges. And I also would like to greatly acknowledge our sponsors. Our presenting sponsor is United Health Foundation. Our gold sponsor is Office of Academic Clinical Affairs. And our maroon sponsor is Medtronic. So that sponsorship allows us to give awards. First place team award is $4,000 sponsored by United Health Foundation. Second place team award, $2,000 sponsored by the Office of Academic Clinical Affairs. And then our third place team award is $1,000 sponsored by Medtronic. And here you're going to meet the finalist teams very soon. 5 really exciting projects on social determinants of health, on demographic inequities, on equity and patient satisfaction and value-based hospital incentives, on hospital mergers and acquisitions and impact on patient experiences, and promoting equity in Medicare's value-based purchasing program. And I really take a note how these teams are very interdisciplinary. They represent 9 schools overall this year. So we're very proud of that. And as I personally always say, healthcare is something we can only tackle as an interdisciplinary team, with an interdisciplinary lens. It's a must. It's not even an option. So with that, I will stop sharing my screen, and I'm going to invite the first team, the impact of social determinants of health to patient experience in hospital setting. There you go. Let's have the team.
Okay, well, we're team 4. I'm going to get ready and share my screen. Can everybody see that? Are we ready to go?
Yep. Thank you.
Okay. Sounds good. Lynn, take it away.
Hello, everyone. My name is Lynn. I'm here with my colleagues, Subin, Brandon, Matthew. Frank and I are excited to present at the Interdisciplinary Health Data Competition. Our topic today is the impacts of social determinants of health to patient experience in hospital setting. Our research is inspired by 3 systematic review studies. The first one is done by Jane Group evaluating the association between social determinants of health in electronic health record and the impacts on analysis and risk predictions. The second study is done by a Davison group proposing the essence of intervention to improve hospital patient satisfaction with healthcare providers and systems. The last study we looked at was done by Ferencvac group, suggesting the negative impacts of neighborhood disadvantage to hospital quality rating in underserved area in the US. Our analysis begins with the current situation in the hospital rating done by the Center for Medicare and Medicaid Services, or CMS in short. CMS uses clinical quality metrics to help patients make informed decisions about healthcare. At the same time, the patient experience is evaluated based on the integral components, for example, easy access to information or good communication with providers and staff. We identify a few major challenges associated with ACMS, including the lack of transparency in collecting data and not being scalable. More importantly, the difficulty of incorporating the rising value-based care strategies to achieve the greater values has not yet been resolved. As a result, patient experience often is discounted from negative impacts of social determinants of health, or SDOH in short, leading to potential readmissions or death. For example, let's take a look at the HCAP survey. HCAP's survey showed Jackson Park Hospital, located in South Chicago, received the lowest scores in communications about medication, care transitions, and recommended hospital categories. This low rating could be contributed by neighborhood disadvantages due to the complexity of metro areas, high density of low-income households, and disparities. Therefore, our proposed solution will help to tackle this issue to improve patient experience and values in care delivery. To better understand the impacts patient experience in hospital settings, we conduct a stakeholder analysis. As you can see in this image illustrates the chains of care. It identifies and prioritizes the factors affecting the patients as the center of care. Doctors, nurses, and staff are involved in the direct consultations and delivering care, while the hospital system indirectly contributed to the improvement of patient health outcomes within the healthcare facilities. Notably, SDOH on the left side and disparities on the right side are often discounted and excluded from the hospital settings. SDOH can affect the values of care, including utilization, cost, health outcomes, and health disparities, not only in clinical settings, but also in hospital settings. Overlooking the patient's social factors is significantly cause of the delivering poor service and quality of care to the patient and caregiver during hospitalization. By using this different HIPAA-compliant media technology method at the bottom, healthcare facility needs to strive to bring these external factors inside their circle of care. Therefore, hospital system must recognize and incorporate SDOH intervention disparity strategies in their training and implementation. Next, my colleague Subin will discuss about data sets used in the future in the further analysis.
Thank you, Lynn. So my name is Subin, and I'll tell you more about our data sources and exploratory data analysis. So based on our situational and stakeholder analysis, our aim of this project was to explore if there are any associations between social determinants of health and patient experience. So to do this, we used 2 additional external data sources along with our required hospital data set from HCAPS. So patient experience data was pulled from HCAPS, and social determinants of health data was pulled from IPOMS and neighborhood ALS by the University of Wisconsin. So social determinants of health data includes economic stability, education, social and community context, health and healthcare, and neighborhood and built environment. So in addition, we use area deprivation index score data, and this is a national percentile rankings from 1 to 100. And this is used to evaluate socioeconomic conditions of regions, and this is linked to health outcomes. So we'll describe this further in detail later in our presentation. So what are the key factors of poor patient experience? To identify these key factors, our team evaluated the US HCAP mean value for each key composite measures, and we found these top 3 factors. So first one is communication about medicines, which measures patients' perceptions of how often hospital staff explained the purpose of any new medication and what side effect that medication might have. Second, it was care transition, which measures patients' perceptions of whether or not personal preference of care is taken into consideration while preparing to be discharged, and also whether or not they are well prepared for a care plan after they're being discharged. Third factor was quietness of the hospital environment. So here is the choropleth map we created using software called Tableau. And this map shows the worst HCAP composite measure, which is communication about medicines. So each marks represents individual county. Red means lower score, blue means higher score. So here we notice that similar areas have low mean scores for all top 3 poor HCAP composite measures of patient experience. So again, these top 3 measures were communication about medicines, care transition, and quietness of hospital environment. So here, let's take a look at some examples here. So Southern California, Florida, New Jersey, and some parts of the New York seems to have poor patient experience outcomes. So I want to point out here that all of these areas are most highly populated parts of the US. So now my colleague Brendan will tell you more about our regression analysis.
Okay, thank you, Subin. So from this slide, I'll explain about our regression analysis. Now, our analysis is based on simple linear regression between the HCAP survey and 5 social determinants. And each social determinant consists of 2 to 9 features. So in total, we have 3 million of IPOM census data that has 32 features. Besides, we use 4 more features that were from Area Deprivation Index, ADI, which will be explained in the next chapter. Among 4 outcome variables, 3 of them are the 3 low score categories in previous slide, and we added 1 more, which is the overall rating of hospitals. Our team conducted numerous simple linear regression between those features and 4 outcome variables. So from next slide, I'll explain the 3 models that have statistically significant result and business context among numerous models we tracked. So for our first model, we used the proportion of white people per county as a social and community determinant. It also identified that each additional 1% increase in the proportion of white population in the county, the score of communication about the medicines increases by 0.044, which is possibly correlated slightly. So this can be interpreted that non-Caucasian population tends to receive ineffective communication about their medicines. Next, we chose number of family as a neighborhood and built environment determinant. As you can see, for 1 unit increase in mean number of family in the county, the score of quietness decreases by 10. So we may infer that the higher number of family members in the hospital can lead to more visitors and hence the result in poor environment condition for patient experience. Lastly, for education determinant, we use proportion of English speakers per county. We can see that for additional 1% increase in the population of English speakers in the county, the score of care transition increased by 0.252. In other words, language barrier in the poor health literacy lead to poor patient experience in receiving care while being discharged. So from next slide, Matthew will explain more about the ADI.
Thank you, Brandon. My name is Matt, and I will discuss The analyses and visualizations we did combining area deprivation index data with the HCAHPS survey data. First, a little background about area deprivation index. Area deprivation index is a composite metric of 17 socioeconomic variables taken from the US Census data. And this composite was developed by the Center for Health Disparities Research at the University of Wisconsin School of Medicine and Public Health. And they make this data available online via their website, the Neighborhood Atlas. These 17 variables that make up the ADI shown on the screen here are combined into a composite score for each census block, and then ranked on a percentile basis on the national level as well as on the state level, giving an ADI national and state ranking for each census block within the United States. The ADI national scores are scored from 1 to 100, where 1 represents the least disadvantaged communities and 100 would represent the most disadvantaged compared to the national average. The state level ADI scores are scaled from 1 to 10 instead of 1 to 100, and they're comparing each census block to the state, with 1 being the least disadvantaged and 10 representing the most disadvantaged of each state. So we downloaded this data, the national and state level ADI data for the entire United States, which is reported at the census block level. And then we imported this data into R and computed the mean and standard deviation of both the national and state level ADIs within each zip code. And then we joined these features with the HCAHPS data set using the zip code of each hospital to join with the ADI data set. And then we did some visualizations and analyses of this combined data set to examine any relationship between ADI and the HCAHPS survey results. Next slide, please, Frank. This is another dot plot map created in Tableau showing the ADI of the zip code for each hospital in the HCAHPS survey. And it's shown on a blue to red scale, where blue, the darkest blue, represents the least disadvantaged communities, and the brightest red represents the most disadvantaged. And with the midpoint 50 percentile being the white color. So one thing we noticed is that there's a large swath of the Western United States where there are regions with high ADI, but there aren't as many hospitals sampled in those regions, meaning those areas of the country with the most socioeconomically disadvantaged communities may be underrepresented in the HCAHPS survey data, which could result in bias in the observed relationship between ADI and the survey data. Next slide, please, Frank. In addition to the data visualization of ADI for each hospital in the survey, we also performed linear regressions in R to assess the relationship between ADI and the various HCAHPS survey questions. Across all of the questions in the survey, there was a significant correlation between ADI and the survey response linear mean scores. And here's just one example showing the relationship between ADI and the overall ranking of each hospital. And as you can see, there is a slightly negative slope, but is a highly significant p-value. In other words, neighborhoods with higher ADI or more socioeconomic disadvantages and higher disparities are likely to receive lower hospital overall rankings. Thank you, and I'll hand it off to Frank for the remainder of our presentation.
Great, thanks, Matt. So just diving into our full evaluation and our summary, as a team, we noticed some strengths and limitations around the data and from the outcomes of our project. Some strengths that we noticed are we were able to easily combine the HCAHPS survey data, the IPUMS data, and the ADI data to put together a cohesive story that I think we're proud of. The ADI information was able to give us a good measure for socioeconomic status, and the IPUMS data contained a lot of information about the social determinants of health. Using our combined experience, The linear regression model that we created to assess those correlations, I think helped support our conclusion. And through our technical means, we had a lot of tools that we were able to use, like Python, R, and Tableau, and Excel to help build a foundation for our conclusion. Some limitations that were highlighted by other members of my team is that we noticed that in the HCAP survey that about only 400 counties had data in the full HCAPS national survey, but the United States has over about 3,000 counties. And comparing that to the area deprivation index, we noticed that a lot of those counties that are outside of those 400 are not adequately represented. So we feel like that was a big gap in measuring and giving information to those communities. The HCAPS measurements and performance index is another limitation, is only containing metrics at the hospital level. We felt like it might be important for that to be contained at the patient level, provider level, or department level, or breaking it up in between hospitals. And then there are some key missing values and information that we feel like were not adequately represented underserved patient populations. And leading into our recommendations, as we went through this project, we broke everything up into 3 categories: education, communication, and equity strategy. And what we mean by education is recommending to hospitals and the systems and the people that work in the industry is to foster environments for fair structures, for opportunities for all the people involved and all of those stakeholders, to make sure that those shared perspectives and everyone is understanding what is going on when they're in that healthcare setting. Talked about previously in the presentation and in some of the studies that we reviewed, communication, language barriers, all external marketing, sourcing, data and community outreach that are involved with a provider or healthcare system should be taken into account in looking at multiple different groups of people that are in the community that hospital is serving. And equity strategy is our third piece. Is to make sure that people are fostering an advocacy culture for patients and making sure that people are understanding the groups and the patients and the communities that they're working with, and making sure that culture is embedded in providers and stakeholders within that hospital. And all of those pieces for our team and our perspective lead into the foundation of value-based care, because that is just something that we think is going to be the future and what is going to help us build the best healthcare system that we can in the United States, and to focusing on that patient-centered approach and supporting multidisciplinary health outcomes. Now on to our implementation of some of our recommendations. As an examples of what we would mean by when we say education, communication, and equity strategy. For education, we want to focus on health literacy and those pieces of making sure anytime anyone ever leaves a hospital, that they know exactly what's going to happen and what next steps are going to be. We mentioned the examples of some hospitals that are receiving one-star scores in Chicago, implementing teach back and show back methods to making sure that when patients enter and exit a hospital, they are feeling confident about what next steps are in their healthcare. And avoiding medical complicated words, making sure that their insurance and their terms and their health is adequately explained to them. And the other studies that we've looked into in our project, translations and communication, multi-language, care notes, and incorporating multimedias and making sure access to documentation is very important for health outcomes. For the equity strategy piece, implementing social determinants of health interventions, making sure that diversity, equity, inclusion is fostered in all aspects of providers and stakeholders within a community is important. And that continues to support value-based care and going into measurable tools, making sure that the data connections and what we're measuring is adequate and how people are progressing along their healthcare plan with their providers is important. In summary, going into our project, our goal is to provide equitable representation for healthcare data and making sure that the measurements and everything that we're reporting is equitable. Some pieces that we noticed that were some issues were social, institutional, and unequitable barriers and how data is recorded, represented, and gathered. And our recommendations, we feel like we've outlined into our 3 categories of education, communication, and equitable strategy. And I think I can speak for us and our team is that our deliverables for this, and we're all going to walk away from this project, is working on ways that we can foster in the classroom and our future jobs and at work, and how we can go through looking through data without bias and presenting our conclusions and actions in a healthy and equitable way, taking into account many and different groups of people. So I think we're really proud of that. I think we did a great job on our project. So thank you for listening, and I appreciate it. We'll take questions now.
Thank you so much. Judges, please chime in. Let's have 5 minutes for questions.
Hello, can you hear me okay? This is Danita Kaiser.
Yes, Danita, thank you.
Yeah.
Thank you. Wonderful presentation. Thank you for doing this and sharing it. I had a couple of quick questions regarding the linear correlation analysis that you did. Did you create a correlation matrix to show the correlation coefficients between the different variables?
So instead of creating the coefficient matrix, actually, we tried the numerous different simple linear regression. Like I think I tried like more than 100, because it might not be easy to represent in the matrix. So rather we just selected a few variables and try like different models. I hope this helps to answer the question.
Yeah. Thank you. And one other quick question, is the ADI per hospital zone, that slide that you had where you show the index from 1 to 100, I didn't quite catch what that index was. Was it based on Z-scores, or was it a different index there?
Yeah, so ADI is it's based on these 17 variables, and they're combined in a way that basically puts it on a percentage scale or a percentile scale. So
okay, got it.
Yeah, I think it's based on a Z-score, but there's kind of a complicated model they use to combine them all together. And they did some analysis to see what they first considered more than these 17 factors, and they found that these 17 were the most significant in their model of economic deprivation. I hope that helps answer the question.
Thank you.
Thank you.
Yeah, I just had a quick question too. So first of all, I thought that was a terrific presentation. I really liked the way you pulled apart some of the data showing how the different both the wealth of the hospital and kind of the economic conditions surrounding, the community conditions really have a negative impact. And you came up with a number of different solutions. And as a longtime quality person, I love being able to run experiments with data. And I wonder if you've given some thought to how to go about evaluating that 12 or 13 recommendations you came up with to see which ones really make a difference and which ones don't.
Thank you for the interesting question. Why are we coming up with this? We read a lot of literatures, and there are several techniques that work, but then however, there are several that did not work. And from as a student pharmacist, I also did my rotation in several hospital and trainings, and I noticed something that works. For example, health literacy and teach back, show back method. I think that works really well. However, in a few hospital settings, they did not really use it. A lot of time provider just came in, explain it, and then they just leave the room without even asking the patient, can you show me how to take this medication? Or let's say if you want to show the neighbor how to take this medication, what would you say? So those techniques really works. I feel like the providers or the staff or the nurses, they will be helpful to have ongoing training for those techniques. Mm-hmm. And also the new one would be technology. A few HIPAA compliant media technologies in place. For example, Microsoft have a new technology that help the patient to, they go into the apps, and they know when, how many people in the emergency room right now and what is the waiting on it. And also they can go to the app and they get all the translation or translator in different languages. It's the PwC, Microsoft is investing it. It's really, I think it's a really nice tool to implement. So in combination with the old fashioned way and then the new technology, I think it will be so helpful to help the patient better experience, with a better experience. And to answer your question, yes, we come up with a few, like a handful of implementation. However, too many implementation at the same time would not work. In our opinion, we should prioritize which one is the immediate problem that we need to tackle. For example, like I mentioned, health literacy and communication, that would be the immediate problem that we need to tackle. And then later on, we can look at a different media compliant media technology to see if we can help use that to help the patient better experience and better communication.
Thank you.
Thank you. Thank you so much. So for the interest of time, I'm going to propose that we move to the second team. But if one of the other judges have a question that they want to ask the team, please use our chat function, and then maybe somebody from the team can respond through the chat to the judging question. So we now welcome, thank you so much, Lynn, Subin, Soko, Matthew, and Frank for really fantastic topic, very innovative. Thank you. Now we have the second team is demographic inequities revealed by HCAHPS ratings.
Hello, everyone. I am Zach Levin from Team 5, which also includes Yi, Koa, and Jeff, who you'll also be hearing from shortly. We're very excited and honored to be finalists in this year's competition. Our project is entitled Demographic Inequities Revealed by HCAHPS Ratings. In our team's early conversations together, we quickly focused on the interplay between structural racism and patient experience. It's not news to anyone here, I think, that structural racism contributes to significant inequities in healthcare for non-white patients. But composite indicators of quality may oversimplify the way patient race and ethnicity impact hospital care. When we looked, most of the existing literature focused on individual patients, but we were really interested in the additional role of place. People live in neighborhoods, cities, counties that have very different demographic compositions. So how does the population served by a hospital factor into reported quality? This led us to our two motivating questions that we attempted to answer. The first is, does racial and ethnic population composition help explain geographic differences in patient experience? And then further, can we unpack the driving forces behind these differences in hospital ratings? So on this slide, we see three maps that are at the hospital service area level. Racial and ethnic distribution are shown on the left, and hospital overall quality indicators from Medicare are on the right. So at first glance, you look at these maps and you think the star ratings do not seem to reflect racial and ethnic distributions in a way that would reveal structural racism with a one-to-one mapping. But clearly, this is an oversimplification because we know there is a strong relationship there. So what we do is unpack the relationship between racial and ethnic composition and outcomes through the lens of patient experience using the HCAHPS data. We focus on the racial and demographic composition of a region and combine that with the voice of the patient as represented in the HCAHPS data to reveal potential focus areas for stakeholders and policymakers to move towards equity in healthcare. So a brief overview of our methodology, our introductory methodology. Hospitals are linked and aggregated at to the hospital service area, also called the HSA, which is a commonly used grouping of facilities that represents a catchment area of patients. These are relatively small geographic areas. There are over 3,000 in the United States. Within the HSA, we average hospital outcomes We then use data from the US Census Bureau to get population statistics on race and ethnicity within an HSA. And then we dichotomize HSAs based separately on their ethnic and racial compositions. And now turn it over to the next speaker.
Okay, here I'm going to present our preliminary exploration results. Yeah, so here we're interested in the differences of the overall hospital ratings in Black versus non-Black and Hispanic versus non-Hispanic HSAs, as we designed earlier. And we have narrowed down our focus to the years between 2018 to 2021. We first plot the unadjusted overall hospital ratings for the two pairs of comparisons and confirmed our initial speculations. Specifically, the overall ratings in non-Black HSAs were constantly higher than those in Black HSAs, and the overall ratings in non-Hispanic HSAs were constantly higher than those in Hispanic HSAs, as is shown on this graph here. We move to the next. Yeah, and on this slide, it shows the exploration results after we adjusted for the HSA level hospital characteristics, including effective delivery, emergency department volume, and so on and so forth. And we have reached similar results to the previous unadjusted model, but in this case, we've seen the divergence was narrowed, reflecting that the rating differences could be partially explained by hospital characteristics, but not all. Okay, move to the next. And now that we've observed the differences in hospital ratings in different racial and ethnic regions, a natural question to ask is, what are the driving forces of these differences? And since hospital characteristics cannot explain all of the differences, what other factors can help with the explanation? So that's what we're interested in. And understanding all these reasons behind these inequalities and kind of disentangling regional demographic and care impact would be helpful for forming an equitable healthcare environment. Next. And following this idea, we asked two more specific questions. The first one, are the different ratings driven by how the population in different racial ethnic regions are treated? And in other words, is it due to some objective reasons? And the second question, can the different ratings be explained by the different preferences, or in other words, some natures or personalities of the population in the different racial and ethnic regions? And in other words, is it due to some subjective reasons? So my team member, Cole and Jeff, will introduce you more about our methods and findings. Thanks.
Thank you, Yi. So just to introduce a little bit of our method behind how to quantify these two sort of reasonings that Yi just introduced before, we will employ the Kitagawa Blinder Oaxaca decompositions. And what it does is that we would quantify how much of the difference in overall hospital rating or patient experience is driven by simply just the difference in hospital characteristics that we see earlier, such as clinical outcomes or timely and effective care, but also subjective measures like how well nurses and doctors communicate with the patients. And we also want to quantify how much of the difference in the patient experience is driven by just the difference in how patients in these two types of HSA value these hospital characteristics. So for example, if the two-type hospital have the same level of mortality rate, would the patients in HSA with higher Black population evaluate this characteristic differently than the patients in the HSA with lower Black population? Next slide, please. Okay, so we'll just show you a quick mathematical formation of the decomposition here. We won't have time to go through all the details, but we're happy to take any questions at the end. So the red expression here shows the difference in our overall patient experience or hospital ratings, like the graph that Yi showed you before. That's the gap. That's the gap, right? So that's the red expression. And then the orange expression is how much of this red expression is driven by just the difference in hospital characteristics, holding, how patients feel about these characteristics the same, right? And then the blue expression, which is the next term, shows how much of the overall experience is, how much of the difference in overall experience is driven by the difference in how patients value these characteristics, okay? So we call this the difference in effects, and then the orange term we call the difference in means, which is the difference in just the means of hospital characteristics. And then the decompositions have two other terms, but we won't go much into details here. But the green term here shows sort of the contribution of the interaction between the two, the first two components. And then the last term is just the difference in constant terms, which is basically letting the two type of HSA on a different slope. Okay. Now I turn it to Jeff.
All right, thank you. So I will present some initial results from our analysis. So when we decompose this difference to try and explain it, first focusing on these objective measures of care. And so these are things like clinical outcomes and timely and effective care. And this is where a lot of the more traditional quality improvement efforts are focused. And we do see that there are some differences here in the ethnic disparity, or the difference between the regions with higher Hispanic populations and lower Hispanic populations. And so we're going to show a series of these graphs. On the left is the difference in means. So that's the different levels of outcomes. So for example, the top one, the hip and knee replacement complication. So does the actual outcome explain this difference for how complications in hip and knee replacement? And then on the right is how these different regions might value or evaluate those complications. And so in this case, we see null results for both the clinical outcomes and the difference in effects. In other words, the outcomes from hip and knee replacements and how populations value those or think about them doesn't appear to explain any of those differences. We do see some small differences here on down on the bottom on timely and effective care, where the flu vaccine for healthcare workers seems to help explain some of that. But as we'll get into in a minute, that's maybe a little bit of sort of a misleading finding. And here we show the difference between the Black HSAs and the regions with lower Black populations. And so we see that there are a number of things that seem to explain the differences in hospital ratings. So mortality rate from COPD patients, mortality of heart failure patients, appropriate care for sepsis and shock, and again, the flu vaccine for healthcare workers. And I will then on the right, draw your attention to the fact that none of those effects are positive. In other words, it's not that these two populations are evaluating or valuing these things differently. It appears to be these actual outcomes. And so we sort of looked at this, but then we thought more about what's driving the HCAHPS ratings, and is it enough just to focus on these objective measures? And so when we include the metrics about the specific patient experience, we find a little bit of a different story. And so this is the comparison between the HSAs with a higher Black population and those with lower Black populations. We saw that there's a very marked difference in how they're evaluating the hospitals. And so I'll start here at the top, and we see that care transitions, cleanliness of the hospital, communications about medications, as the last team mentioned, and quietness all seem to be very positively associated with that difference. In other words, they help explain a lot of the difference. And then looking at the right, we see that it's not that these populations value these things differently or appear to have different expectations, anything like that. And then the other thing I'd like to draw your attention to is essentially the null results for most of the clinical outcomes, which tells us that it's not just the quality of care or the outcomes that are driving these differences in hospital ratings. The other thing that is really important here is that there are many sort of upstream precursors that can impact those outcomes. They'll impact the hospital's patient mix, the severity, the socioeconomic conditions that could potentially worsen some of these conditions. They're not explaining the difference in the outcomes. It's really the differences in the specific patient experience that are explaining the different hospital ratings. One interesting finding from this slide that I'll point out is the doctor communication coefficient is actually negative. And what that tells us is that doctor communication is reducing the gap. In other words, it appears that the doctors are doing a really good job communicating with their patients. And if they weren't doing the job that they are doing, that the gap would actually be worse. And so this is something that I think is really significant, and we'll hit again during our contributions. But this method and this type of analysis, when performed, say at the hospital or the HSA or the system level, can indicate where you're doing really well and where you need to do better, even if overall there's still a long way to go. When we look at the regions broken down by their ethnic populations, we see very similar results. Again, we're not seeing large impacts from clinical outcomes or timely and effective care, some of those more objective measures. And we're seeing that the difference in the contribution of means is, the difference is largely coming from the difference in means. So these are the outcomes or the evaluations of nurse communication, quietness, staff responsiveness, care transitions, and cleanliness. We do see one significant result over on the right side, which is on the care transitions category, which tells us that this is maybe potentially more important, which may be related to the analysis that the team that presented right before us showed regarding the percentage of the population speaking English, things like that. Although we don't see big differences in how they're evaluating nurse and doctor communication, but that may potentially be due to availability of translators, which are generally going to be more available for doctor and nurse communication, but may not be available during some of those transitions from the hospital to a skilled nursing facility, for example. So to sum up and highlight the contribution that we think this provides, this HSA level analysis considers the impacts of demographics and the neighborhood where hospitals are located, the populations that live there. And by using the KBO decomposition, it provides actionable insights at the hospital level, indicating where the hospital should focus and really taking into account the voice of the patients. What are the patients actually asking for? And it also helps, I think, can be used as a tool to refute some things that may be said, that, well, patients evaluate this hospital lower because of their pre-existing conditions, or, well, it's because of the patient's outcomes, which the hospital could only do so much to impact, and that's why they're giving us these low scores, things like that. On the flip side, it can highlight, even in a hospital that's not getting great scores, it can highlight areas that the hospital is doing a good job. So for example, if your doctors are doing a great job communicating, you don't want to yell at the doctors and say, hey, the reason we're getting low scores is because of poor doctor communication. You need to do better, when the doctors are already doing everything that they can do. So it allows you to really target the resources that will have the most impact. And finally, this really gives us a lot more insight into sort of very aggregate high level scores in a way that we can maybe better understand them and take action. So with that, we are happy to take questions.
Thank you, team. Judges?
Well, I'm happy to ask a question. Wanted to give a few others a chance. I was really interested in the last couple graphs that I think, Jeff, it was you that were speaking to. And I might be misinterpreting it, but it looks to me like what your data is showing is that there's not a significant impact on outcomes based on the patient experience. Am I reading that correctly?
It's sort of the other way around. So in this graph, what we're using is the clinical outcomes as a potential predictor for the overall hospital rating. And so a way to sort of think about this is, would improve, let's say a hospital wanted to improve their overall hospital rating, and they said, okay, so what we're going to do, we're really going to focus on these clinical outcomes. We're going to focus on improving our mortality rate. We're going to focus on improving the heart failure rate in order to reduce this gap or this difference in care that we're seeing. And we feel that this difference represents an inequity in healthcare. And so would resolving potential differences in clinical outcomes help close that gap? And what we're finding is that it would not, that there's still something else that needs to be done.
Mm-hmm.
Do we have other questions from other judges?
I was trying to give people room to ask. I was curious how you calculated the regression coefficient in the blinder-Oxata decomposition. How did you estimate beta?
Yeah, so the beta was essentially estimated using separately for the subsample of the HSA with higher Black population, and the regression separately for HSA with lower Black population, and same with Hispanic.
Okay, thank you.
Mm-hmm.
Okay, well, I think if there are no other judging questions, and judges, please feel free to type in the chat if some questions come up for the team that you couldn't get a chance to ask. We thank Jeff, Zach, and Kwa, and Yi, and we move on to the third team, equity and patient satisfaction in value-based hospital incentives. Thank you.
Okay, so hi everyone, we are Team 10, and our team consists of Shorodipito, Christian, Mihalo, Simeon, and Ihan. Today, we could go to the next slide. So today we are going to use the provided hospital satisfaction data to explore how value-based hospital incentives could influence the social equity and the patient satisfaction. So first of all, here we present some basic backgrounds. The Centers for Medicare and Medicaid Services launched the Hospital Readmissions Reduction Program in 2010. Actually, this is the first of it is one of the first nationwide value-based incentive programs. This program actually sought to promote quality of care by reducing Medicare payments for hospitals with relatively higher than expected 30-day readmission dates. We'd like to focus on this specific project because it is a quite influential one. As demonstrated in the news article here, we know in the past 10 years, actually, Medicare is reducing its payments to more than 2,000 hospitals, which takes up about 47% of all the facilities. It is also, we know, it is shown that the program successfully reduced the reported readmission rates. Could we go to next slide? However, although the house readmission rates did dramatically fall after this program was implemented, researchers have suggested that this program could have some undesirable side effects. First of all, it might disproportionately penalize the minority serving hospitals. Also, the program could fail to improve the patient satisfaction. So now we have the patient satisfaction data set. We use this data set provided. We try to explore whether this program really enhanced the patient healthcare experience. In short, we'd like to do this project. What we'd like to do in this project is to test whether this program penalizes hospitals that primarily serve minority patients, and whether the attained readmission rate decreases translate to a relatively higher patient satisfaction. Now let me teammate to further introduce how we conduct this project.
Yeah, so the first thing we set out to explore was just to get familiar with the HCAHPS data itself. And what we were curious about was the correlation that we see amongst the variables in that survey. And so here's a correlation matrix visualizing the correlations between those variables. And what we can see is that there's nearly a uniformly high correlation across all of these variables. And what that signals to us is we need to be somewhat careful when we consider how many of these variables we consider in a future model, because they are conveying somewhat similar information. The next thing we want to look at was for the CMS hospital data. We needed to consider some special features of the data that correlate to or corresponding to variables that were reported as rates and as scores. Now, they're particularly tricky because in their documentation, they report the scores and rates as not being actual measurements from the hospitals, but rather predictions. And this can lead to a tricky pitfall. We called it circular logic, that you can imagine that if you were to model the association between a variable that's reported as a score and another variable, well, if the variables that you're considering were used to predict one another, well, then you see by definition, because they're used to predict one another, a high correspondence between them. And so here's an example of a potentially difficult set of variables corresponding to the complication scores at a hospital and the overall hospital rating. You can imagine how the complication scores might be used to compute the overall hospital rating. And thus, we would see a very strong relationship, although it would be an artificial relationship just because of the predictive, the way in which the score values are calculated. And so what this would do is it would lead to a low external validity of our methods. Basically, you can imagine if we were to compare this with other data sets or even year-over-year data, our model might not be so good at making the same predictions. And so because of this, we only considered variables for which this amount of circular logic was either negligible or potentially non-existent. So with that, we'll describe the first set of exploratory results that we considered. And so here we have a set of graphs that correspond to the HCAHPS data, as well as a couple other variables with payment and Medicare payments. And the first thing we wanted to do was just look for a simple difference in group means. And in this case, we're looking at differences in group means based on hospital ownership. So the color of these boxes is based on hospital ownership. And while I'm not going to discuss any of the particular results of this, I just want to point out, you can notice some of them are similar, some of them are different. And the tribal, the purple box plots, oftentimes show maybe some very different results from the rest of the hospitals. However, we just want to put an asterisk by that because oftentimes the sample size for tribal hospitals was very small, sometimes even only having a sample size of around 4. And furthermore, the significant results that we actually see here don't really translate into an interesting story about the data or an actionable set of outcomes. And so with that, we kind of upped the complexity of our models.
So as we just saw, there's not much of a difference between the different types of hospital ownerships based on the ratings when we compared group means. So now we continue to perform an exploratory visualization by comparing group trends instead. And if we plot the different types of scores and ratings, like the comparison score, overall hospital rating, recommend hospital, and spend per patient, we see there is not much of a difference between the different trends either. In particular, if you look at the correlation values, the correlation for government ownerships and private ownerships are very close to one another almost all the time. It is to be noted, however, that the tribal ownerships differ from their government and private counterparts in terms of the correlation. But as Christian pointed out, the number of data points under tribal ownership is very less. And so taking them further in the analysis could lead to unreliable conclusions. And so we do not pursue them further in the analysis. Instead, we start performing an exploratory, a spatial exploration, and we plot the county level data first in the map of Minnesota. We plot the readmission rates, Medicare spending per patient, and payment, and see there exists a correlation indeed, in the sense that the counties that show high readmission rates have low Medicare spending per patient and low payments, and vice versa. If we continue further on the map of Massachusetts, the same trend is reflected. High readmission rates correspond to low Medicare spending per patient and low payments, and vice versa. And if we continue to plot the same data or similar data on the map of California, exactly same is reflected. High readmissions corresponding to low Medicare spending per patient and payment, and low readmission rates correspond to higher Medicare spending per patient and payment. Based on these observations, we finally decide to incorporate overall hospital rating, the payment variables, and the census data as the predictor variables, and the readmission rate as the variable of interest or the predicted variable. It is to be noted, however, that the missingness for readmission rates in different counties are highly correlated with the Medicare spending per patient. Next, Simeon will continue with the method.
Okay, hi, I'm Simeon. We have defined the readmission rate to be the ratio of number of patients readmitted to the number of patients discharged. And as we expect a complex nonlinear relationship between readmission rate and the other variables, we decided to use a regression tree over linear regression, as regression tree is more flexible and interpretable, and as well as captures nonlinear association as well. So how does a regression tree works? It splits the covariate space into a few regions and predicts the outcome for a data point based on in which of the region that particular data point is in. It does so by sequentially identifying the best variable and the threshold value for that particular variable, and sequentially splitting the covariate space using those threshold value and the variables. We have reported the model fit as the mean square error, which is the mean of the square of the differences between the prediction value and the outcome variable, original outcome variable. And the performance of the model has been assessed by using leave one out cross validation error, which we will refer to as the LOOCV error. The LOOCV error is calculated by excluding one data point from our training sample and then fitting the regression tree on the rest of the data point and then predicting the outcome value for the left out data point. We do this for each of the data point. So for each of the data point, we obtain a predicted value and outcome and the original observed outcome value. And we ultimately report the LOOCV error as the mean of the square of the difference between the predicted value and the outcome value. So in the next slide, we have plotted the regression tree that we have obtained by fitting it on the data set. You can see that the staff responsiveness, the overall hospital rating, payment, and the complication score are the most important. predictors. I will explain the left sub branch of the decision tree. So for example, if you have got a data point and we first look at staff responsiveness, which is there at the topmost tier. So we'll ask whether, we'll see whether the staff responsiveness is less than 84.5 or not. If it is yes, we will then check the overall hospital rating and we'll ask whether it is less than 86.5 or not. If the answer is yes, we will predict the readmission rate to be 0.2908 for the data point. If it is no, we will predict the readmission rate to be 0.2662 for the data set. We have found out the LOCV error is 0.00514, which is actually an indicative of a very good fit for this regression tree. Next, in order to improve the prediction accuracy, we have fitted a random forest model as well on the data set. So in the random forest, we selected 100 bootstrap sample to create regression tree like this one, like the one that I just explained, for each of the bootstrap samples. By bootstrap sample, I mean a simple random sample with replacement of the same size as a data set. And we ultimately report the average of the 100 trees as the random forest that we obtain. So we are kind of trading the interpretability for the prediction accuracy, because as you can see, we are taking average of 100 predicted values. The variance is bound to decrease, which is indicative of the prediction accuracy. We have reported the variable importance as the number of time, as a percentage of time the variable was included in one of the 100 bootstrap trees. And obviously a high variable importance is indicative of the high influence of that particular variable in predicting the outcome. We also obtain a LOCV error for the random forest model as well. We found it to be 0.00428, which indicates a better performance than a single regression tree, and it is also indicative of an excellent fit.
Thank you, Simeon, for explaining why a random forest model is appropriate for us to be able to judge the relative importance of different variables in this setting with high collinearity and potentially nonlinear relationships. So here are the results of the random forest model. On the vertical axis is the percent inclusion, which was the percentage of times that each variable was included among the 100 bootstrapped iterations in the training process. And on the horizontal axis are all the different variables that we considered in the model. So I'd like to point out that on the one hand are the variables with a very high percentage of inclusion. So these are payment and Medicare spending per patient. Now, that makes sense because as we know, the HRP program, which had been going on for nearly a decade by the time this data was collected, that program decreased Medicare payments to hospitals with high readmission rates. So obviously, these two variables would be important predictors of readmission rates. And in a sense, this serves as a positive control for a model. The model is indeed capturing a relationship that should exist given what we know about the program. And so that helps to justify that the other relationships that are present in the model do exist and aren't just artifacts of the training process. So on the other extreme, we see that all of the race variables, which were measured at the county level, for all of the racial categories, they are very low on the inclusion percentage, which means that they are not important predictors of hospital readmission rates relative to even things such as the patient satisfaction measures. Cleanliness is pretty high up there, and things like whether the patient would recommend the hospital and staff responsiveness are all around that 20% inclusion line, which means that they are fairly important. But the racial categories across all racial categories as measured by the US Census are actually not important predictors of hospital readmission rates. So going on, let's summarize the results from these various statistical and machine learning analyses and draw some conclusions. So first of all, I'll note that as we saw at the beginning, tribal-owned hospitals seem to be outliers in the sense that the correlation between patient readmission rates and various HCAHPS survey measures seems to be reversed for tribal-owned hospitals relative to public and private hospitals. But due to small sample sizes, more data is needed to definitively test this conclusion. We also noted that missingness for readmission and Medicare is highly correlated. This means that if a hospital doesn't have data on readmission rates, it's probably also not going to have data on the Medicare payments made at that hospital. And while this doesn't tell us anything on its own, it suggests that any kind of spatial analysis, whether that's looking at HSA level data or county level data, might be biased because of the high amount of missingness in the available data sets. If this missingness is not completely at random, then no matter what statistical model is used, it would not be able to correct for potential bias stemming from that. So with that said, what we can definitively conclude is that there is a relationship between readmission rates and Medicare payments, and that's detected by a random forest model, which is able to account both for things like multicollinearity between variables, nonlinear relationships among the variables and the predictor, as well as things like model misspecification and overfitting are all accounted for by the bootstrapped training process we use. So this is a robust relationship, and it's consistent with the HRP program objectives. But more importantly, that same model shows that there is no difference in readmission rates across racial categories. While it is certainly important to identify factors and variables that exhibit racial disparities, we believe that it is just as important to identify variables and factors that are not associated with disparities across racial or other demographic categories. As the healthcare system continues to grapple with issues like systemic racism, it is important to understand which variables do show evidence of inequities and which ones don't, so that appropriate measures can be implemented. And finally, we note that readmission rate decreases are weakly associated with patient satisfaction, and this association is negative. So finally, we would like to put forth 4 policy recommendations for healthcare administrators and public health professionals. So first of all, our analysis confirms that negative reinforcement through value-based incentives, such as that done by the HRP program, can indeed lead to marked improvements in quality of care. But more importantly, what we uncovered was that targeting readmission rate does not exacerbate racial disparities between hospitals, since all of the racial categories, at least according to the census data at the county level, are not associated with readmission rates according to this model. Furthermore, we find that staff responsiveness and other measures of patient satisfaction are fairly good predictors of readmission rates, with lower satisfaction leading to higher readmission rates. This suggests that programs which want to improve both patient satisfaction and readmission rates can target the same set of factors, since these two are closely interrelated. And finally, we call for further research in order to rigorously identify geographical differences in the efficacy of value-based incentives, since due to high levels of missingness, such analyses on currently available data might not be valid. With this, I'll leave you with some of the references we used, as well as our data sources, which include, of course, the HCAHPS data and other data sets provided by the CMS and the American Community Survey from the US Census Bureau. Thank you.
Thank you so much to the team. Judges, would you like to jump in with a few questions?
I've got one to start, Bernard. First, I really appreciate the sophistication of this analysis. I would ask the authors, though, whether or not they've checked their results against the literature. Specifically, does the literature indicate that race is associated as a predictor of increased readmission? And if it is or it isn't, how do you value the application of a model like this against published literature? And then the second question is maybe philosophical, and it may seem odd. We are reimbursing hospitals less who have a higher readmission, and it's effectively a penalty that deprives hospitals of resources they might need. And it's really a philosophical question. I was curious if the authors had any thoughts on that one.
Yeah, thank you for those questions. Oh, go ahead.
Okay. Oh, sure. Well, your question really touches on the complexity of it, clearly, and more so highlighting what we anticipated being nonlinear effects, right? So it's not clear that having a readmission rate that's higher will always lead to like X, Y, and Z. So that's why we used nonlinear models, like we said, like with the regression tree and the random forest. And so but the drawback of that, as I think you're pointing out, is that there's not a neat and tidy inference placed on like how exactly strong like the relationship is, rather that they are important for explaining one another. It's not that we can say increasing, say, funding by a certain dollar amount is anticipated to affect the readmission rate by another dollar amount. So in essence, I mean, while we can interpret variable importance, it's not clear as to whether it's going to be a smooth effect, whether, like I said, readmission rates will correspond directly to just like a linear association with payments. Rather, it's just a more loose fit of that. I don't know, Mikhailo, did you have something to say on top? Or?
Yeah, no, that's basically an important point where with choosing to use a more complex modeling approach from the machine learning literature, this sacrifices inference in some sense. So it's impossible to claim any kind of causality analysis from these variable importance results. And as for the question about the second part of the question, in terms of reducing, the philosophical question of whether reducing payments can have, like how that would actually help since it's depriving hospitals of needed resources. And yeah, I certainly agree with that. And again, this type of model, while it can point to variable importance, we can't draw like a causal direction from one thing to the other from the analysis. And in terms of, I think the first question also asked about literature. So yeah, we did encounter literature that has.
I can.
Okay, sure, go ahead.
Yeah, so one point I would like to add is most of the existing literature uses granular data, like a patient level data, where we actually incorporate the person's race and their outcomes in particular. But the data set we were provided with was our hospital level data. So we didn't exactly know the counts of people who are actually Hispanic, Black, White, or Latino, or Asian. So that was a big hindrance in our part, using a granular data like that. Maybe we can explore further if we got a patient level data set.
Thank you. Excellent answers.
Thank you. Is there another judge question? We could do one more question. Okay. Well, thank you so much to our competitors for this particular project, Christian, Simeon, Sorodipto, Mikhailo, and Ihan. And now we move on to the team, the effects of hospital mergers and acquisitions on patient experience.
Great. Well, thank you all for being here today. Finn and I will be presenting the work of Team 12, and we this year looked at the effects of hospital mergers and acquisitions on patient experience. So as you can see from this graph showing the number of hospitals mergers and acquisitions between 2011 and 2021, the number of mergers and acquisitions was slowed a bit by COVID-19. However, it does appear that some big systems may be using their federal COVID aid to buy up other hospitals and further consolidate the competition. This seems to be related to a larger ongoing trend within the merger and acquisition space. Many industry experts have suggested that hospital mergers and acquisitions are becoming larger, meaning that the total dollars allocated for these transactions is larger and the size of the hospitals being acquired are larger. So there are both critics and proponents for hospital mergers and acquisitions. Critics argue that these transactions can potentially increase the cost of care for patients and also contribute to deteriorating quality, with some even suggesting that mergers and acquisitions be stopped completely. Proponents, however, argue that mergers and acquisitions can contribute to better patient outcomes, increased access of care, stabilized rural access to care, and increased innovation. But don't just hear it from us. We are going to also hear from the former chairman of the board of the American Hospital Association, Brian Grignolti. So it looks like our video was not working here, but let's see if we can.
It is not. Wow. Okay. It worked in the pre.
Finn, should I try?
Let me give this another try.
Okay.
No, media is not playing. Anyway, to quickly summarize, so Brian shares on this video, which is a 1-minute video that you can find on the website of the American Hospital Association, where this association maintains a dedicated website just for the benefits of mergers and acquisitions. So they are lobbying hard to have mergers and acquisition viewed positively. And he argues that mergers oftentimes increase the quality of care, that mergers and acquisitions are often the only chance for small hospitals to have innovation, because they join these larger hospital systems, and those larger hospital systems provide the smaller hospitals with processes and with innovation. And also that mergers and acquisitions are oftentimes the only way to preserve access for rural communities where maybe the local hospital can't afford to operate on its own. But by joining a larger healthcare system, it might actually have enough resources through splitting resources like accounting with other hospitals to continue operate. So mergers and acquisition also provides an avenue for access in rural communities.
Thanks for that quick summary, Finn. So now that we understand the benefits and drawbacks and also the trends related to hospital mergers and acquisitions, we arrive at our question that we asked: how do hospital mergers and acquisitions with healthcare systems affect patient experience? By answering this question, we hope to contribute to the discussion surrounding hospital mergers and acquisitions, as Finn kind of described through our video, and understanding the pros and cons. One challenge we did face when answering this question was that though there is merger and acquisition data widely available, much of the detailed data is proprietary, and so it was not allowed in the context of this competition. So instead, we used data from the Agency for Healthcare Research and Quality.
Yes, thank you, Lexi. So the AHRQ provides a compendium of US health systems for 2016 and 2018. Within this compendium, they list all hospitals and to what health system these hospitals are associated. So very naive procedure for estimating the effect of mergers and acquisitions on patient experience would be to look at what hospitals joined a healthcare system in 2018, and then look at the patient experience outcomes for these hospitals. As the team before us pointed out kind of in their conclusion, by doing that, we're not getting at any causal effect of the effect of mergers and acquisitions. However, what we are after is getting towards a causal effect to see how this causes changes in patient experience. Therefore, we first turn towards panel data. So instead of using the 2021 version of the HCAHPS data, we went back to 2014 and collected the HCAHPS data for all years between 2014 and 2020 onset of COVID. We then took the compendium of the health systems and looked at changes in the association of hospitals with the healthcare system between 2016 and 18. Doing this gives us 5 options of what can change in the hospital. The first option is an independent hospital that stays independent. We use these hospitals as a control group to observe if there's any time trend in the patient experience data between different years. Also, a hospital that was associated with the health system and remained associated with that health system through 2018 also had no change, and we use it as a control as well. Then there's a small group of hospitals that were associated with the health system in 2016, but then became independent in 2018. We include these hospitals in our first analysis, but later drop them and focus on the main number of hospitals, which are hospitals that were independent in 2016 and joined a health system in 2018, or that were associated with one health system in 2016, but then were associated with a different health system in 2018. So these two that experienced a change in the association with the health system are our treatment group, and then the hospitals that were independent and stayed independent are control, and also hospitals that were associated and stayed associated. We looked at some other data to infer if any of the hospitals had a merger or acquisition in the years 14, 15, 16. While we don't have data from the AHRQ, we tried to collect other data and dropped any hospital where there was any indication that it had a merger and acquisition to kind of be on the conservative side for our estimates. Also, because we don't have the exact date of when these hospitals changed into a health system, we drop all data from 2017, as it could be that some hospitals changed in 2017 and others changed in 2018. Given this data availability, we refine our question and ask, how does changing the healthcare system between 2016 and 18 affect patient experience? And how does the patient experience of the absorbing healthcare system, so the kind of experience level across all hospitals in the health system as a proxy for this is how good in terms of patient experience that particular health system is, affect patient experience of the joining hospital. So that hospital that was independent or associated with a different health system and now joined the absorbing healthcare system. Empirically, we look at the overall star rating of hospitals, which we got from the CMS HCAHPS data. And our predictor variables are year dummies, so 14, 15, 16, 18, 19, and a change in health system dummy. So if the health system changed between 16 and 18, as you saw on the earlier slides. Our specification then is a difference in difference approach, where we have one dummy variable for the change in health system and a second dummy variable for any year that is greater than 2018, so after the change. We then have an interaction term between hospitals that changed the health system and years 18, 19, 20. And that coefficient delta, here highlighted in red, is our coefficient of interest, and we map it in the following slides. Also, we use hospital fixed effects and year dummies to eliminate any hospital-specific unobserved effects that are time constant or any general trends in the patient experience across all of the HCAHPS data. Just naively mapping the coefficient for the change in health system. So this is now the delta coefficient from the previous specification, shows us that a merger and acquisition has a negative effect on the patient experience in the following years. However, this is for all hospitals, also those hospitals that become independent. So now we look at only those hospitals that joined a healthcare system or changed the healthcare system, and we see that this coefficient remains mostly stable. It became a little less negative on the margin. So first research question that we had is answered. It seems to have a negative effect on patient experience in terms of overall hospital star rating if hospitals are involved in the merger and acquisition. However, are there differences in what healthcare system they are joining? So we continue to use the main effect of a change in health system, but we also include an interaction term between this variable and the quartile of the patient experience of the absorbing health system. So Q1 means that the health system that is absorbing the hospital ranked in the lowest quartile in terms of patient experience in the years prior to the merger, while Q4 means that it ranked in the highest quartile in terms of patient experience. What we see here is that compared to joining a Q1 hospital where the effect is minus 0.2 on the overall patient experience, there's actually a positive interaction term for joining a very good hospital in terms of patient experience that offsets the negative effect of the change in health system. For the Q2 and Q3, we don't see any significant interaction term. So it appears that mergers and acquisition disrupt routines in hospitals, and the literature tells us that disrupted routines by, for example, new processes that the new healthcare system imposes on the existing hospital might lead to higher workload. Furthermore, we know that higher workload might lead to a saturation effect where employees can no longer keep up. And therefore, maybe the overall hospital star rating might be deteriorating. If this were the case, we would expect that variables such as staff responsiveness also suffer, while other variables, such as discharge information or quietness, are not affected by the merger. In fact, if we run the same regression just with the staff responsiveness as our dependent variable, we find that there's a minus 0.2 change in the healthcare system merger and acquisition coefficient. And we see that joining a Q3 or Q4 hospital, as before, has a positive effect that offsets the negative effect of mergers and acquisitions. So this supports the finding that it might be new processes that lead to worse staff responsiveness that might lead to an overall lower star rating. We don't find any significant results for discharge information, for example. There are 3 levels of policy implications. First, for the joining hospital. For the joining hospital, these hospitals should consider patient experience of the health system that they are planning to join if they have choices between multiple health systems. If they don't, they should at least be prepared to stand up for their processes if they have good processes. For the absorbing healthcare systems, healthcare systems should first focus on their own process improvement before expanding and merging and buying other hospitals. Especially if you are a poorly performing healthcare system and you are planning to buy a high-performing hospitals in the hope to boost your own performance, that might actually just lead to you disrupting the patient experience at the high-performing hospital. Lastly, for the merger and acquisition discussion, merger and acquisition effect on patient experience are not black or white. In fact, the performance of the absorbing healthcare system matters. So that should be considered when discussing this between advocates and critics of mergers and acquisitions in the healthcare space. In conclusion, joining a healthcare system between 2016 and 18 reduced the subsequent patient experience. The effect is stronger when joining bad healthcare system as opposed to good healthcare systems. And processes and workload should be considered when integrating hospitals. Some of the limitations here that we might explore in follow-up studies to what we did here is that we only have dates for 16 and 18. So we don't know exactly on what date a hospital merged with the healthcare system. This data is available via the Wharton Research Dataverse, which we have access to, but proprietary in the context of this competition. Also, there's some overlap in the outcome measure in the HCAHPS data where they switched the reporting term. So some of the 1890 data is overlapping, which might create a small bias in our results. Lastly, there is the risk that high quality hospitals might select hospitals with a positive trajectory in terms of healthcare experience to buy. However, this is alleviated by the fact that it's not the level, but the trend in the patient experience that we are looking at. So this is not all too concerning. For your information, we have references and data sources listed and are open for your questions. And I see that David already got his hand up. So we might start with you, David.
Yeah, thank you for this. What you described is important. I would encourage you to extend this analysis. When mergers and acquisition occurs, the transition period is often difficult. And so with the relatively short time frame you're looking at, 16, 18, you may be essentially measuring the most challenging period of the transition. But because these discussions are so important nationally, it would be worthwhile to see whether this data settles differently sort of 3 to 4 years after an M&A occurs. Thank you.
I absolutely agree, and that is part of the limitations given that we only have the 16, 18. So ideally we would want to have dates for mergers maybe in 14, 15, where we have a longer kind of post-treatment period, which is something we would definitely do in a follow-up if we ever were to pursue publishing this work. Thank you.
Yeah, great job on that, and I agree with the prior statement that looking longer term is going to give you a little better sense of what the outcomes are. I'm wondering though, if you turn it around a little bit, you were looking at the rankings of the acquiring hospital. I wonder how the rankings of the acquired hospital might also play into this. So a highly ranked hospital that got purchased by a poor ranked hospital, for example, does that, or system, will that change things around?
good question. We did not look at this. We take this under advice.
Take it under advisement. Yeah, I think it'd be really interesting.
Okay, do we have Rich and Danita, do you have any questions?
Actually, no, I think Mark and David brought up some very good points. And coming from M Health Fairview that recently acquired Health East, I don't know that I'm allowed to ask questions.
We didn't think of that angle. Okay, thank you, Rich.
No, the only observation I had, and this, you, by the way, you did a great job, Finn, on saving that video not playing. I can't tell you how many times that's happened to me. It never fails, right? Great save there. But one thing I noticed is that, you know, the M&A activity decreased during COVID, but I wonder if there's some data somewhere that could determine the impact of just hospital closures and during that past couple of years during COVID, and because I'm not sure specifically in rural areas, a lot of hospital closures impacted, you know, patient access to care and corresponding load on the physicians and providers in the nearby healthcare systems. So just a comment, no question was in there.
Thank you.
Thank you.
Thank you.
Great, thank you so much to Yasman, Arundam, Finn, and Lexi. We now have our last team, team 5, or team number 5 in this order, promoting equity in Medicare's value-based purchasing program. Emily and Alex.
Make sure this worked correctly. All right. So, hi everybody. Thanks so much for being here and for sticking it out with us to the end. My name is Emily and I am here with Alex. And today we'll be talking about the equity impacts of Medicare's value-based purchasing program using our analysis of the HCAP experience data. So for our analysis, we used the most recent HCAP dataset, as well as the general information and complications and death files from CMS. We also used Census Bureau data on race and ethnicity, as well as median income by zip code, and US Department of Agriculture data that assigns a rural-urban continuum code to each county in the United States. Before we discuss our analysis and recommendations, we wanted to give a high-level overview of the final data set we were working with after combining the data from all of those sources. So our final data set had over 4,800 hospitals and responses from 1.9 million completed surveys. The average response rate was 24%, and the data spans all 50 US states, as well as DC and 5 US territories. Of the hospitals that are included in the data set, almost 28% are designated as critical access hospitals. One thing to note is that critical access hospitals are not required to participate in the HCAP survey, but they can if they choose to. 80% of hospitals meet CMS criteria for promoting interoperability, which encourages eligible hospitals to demonstrate meaningful use of certified electronic health record technology. So 61% of the hospitals you're looking at are designated as metropolitan by the USDA, and 39% are designated as non-metropolitan. As for hospital ownership type, 58% are nonprofit, 25% are government or tribal owned, and then 17% are for-profit. One other thing to note about the data, though it's not listed on here, is that survey exclusion criteria limits responses to patients older than 18, those with non-psychiatric related admissions, and patients that are discharged home rather than to a skilled nursing or transitional care facility.
The first thing that we looked at to inform our research direction was that the HCAPS survey data are being used for. We found that the HCAPS survey scores impact Medicare fee-for-service payments to hospitals through the value-based purchasing program. This value-based purchasing program was rolled out in 2012 as a way for CMS to link Medicare payments to quality of hospital care. 2% of Medicare payments are withheld from participating hospitals, who then receive a yearly reward based on their performance on these 4 measures you can see here on the slide. This is made up of clinical outcomes, safety, efficiency and cost reduction, and personal and community engagement. As you can see, the HCAHPS scores fall under the personal and community engagement category. To give some context on these payments or rewards that I discussed earlier, for the fiscal year 2021, the largest penalty was 1.7%, and the largest reward was 2.9%. This 1.7% penalty actually means the hospital in question received only 0.3% back of that initial 2% that was withheld. And if you compare this to the 2.9% reward, where the hospital received the initial 2%, of course, as well as an additional 2.9%. So that represents a 4.6% difference in payments between the highest and lowest performing hospitals, which is a notable amount given that Medicare fee-for-service payments make up a large proportion of hospital revenues each year. Given how wide the difference is, we began to wonder, who are the winners and losers of this program, and what is the impact of this program? So based on historical and current inequities in healthcare, we suspected that equity might be an area for improvement in the value-based purchasing program, particularly if hospitals that serve poor or minority patients end up being disproportionately penalized. As we know, there are already a lot of racial disparities in healthcare. So on this slide here, you can see the results of 2 studies, one that looked at hospital assets by race of the patient population, and another that looked at the risk of mortality in minority versus non-minority hospitals. As you can see, Black and Hispanic serving hospitals already have less capital assets and new asset purchases than other hospitals. At the same time, Black and Hispanic serving hospitals have a higher risk of mortality and sepsis. Given that minority serving hospitals already have less resources and higher rates of certain adverse outcomes, such as sepsis described here, equity needs to be a critical feature of any new program that impacts hospital resources. As we transition from a fee-for-service-based healthcare system to a value-based one, it is critical that the design of these value-based incentive programs should not exacerbate existing racial disparities. So with this in mind, we focused our analysis on the concept of equity in the value-based purchasing program. Our key research question became, are current methods of risk adjustment for HCAHPS sufficient for producing equitable incentives under the CMS value-based purchasing program?
So looking at our data set, one thing that we found is that racial disparities do exist in responses to the question about an individual's likeliness to recommend a hospital. We chose to look at that particular question because it's an overall measure of patient experience as opposed to a specific category. We used the Census Bureau race data to categorize hospitals into the groups that you see on the slide here based on their zip code. It's important to acknowledge that because this is based on zip code, it is a proxy for the demographics of the patient population, but it will not be accurate for every hospital. So on the left, you can see that as percentage of white residents in the community goes up, scores improve for this question about likelihood to recommend the hospital. And you can see that because the amount of green is going up, which is yes, I would definitely recommend. And the amount of red is going down, which is no, I would definitely not recommend. And on the other hand, if you look at the chart on the right, as the percentage of Black residents in a community goes up, the scores for this question go down. So we looked at the same breakdown by median income for the community as well and found a similar pattern where an increase in income led to an increase in responses to this question. So we're starting to see that there are disparities in patient experience responses by race as well as by income. But responses to the HCAHPS survey are adjusted before the overall patient experience score is calculated for each hospital. So first, individual survey responses, like the one we just talked about on the last slide, are adjusted based on the categories you see here on the right. These adjustments are designed to control for some social determinants of health before scores are calculated and translated into hospital payments or penalties. So one thing to note is that race and income are not explicitly included in the adjustment categories. Then after adjustment happens, the responses from similar questions are combined into composite measures called linear mean scores, as we've seen earlier today. And for example, there's a singular linear mean score for doctor communication, for cleanliness, for staff responsiveness, et cetera. And these scores are then reported to the public, and in conjunction with the other 3 categories for the value-based purchasing program, payments or penalties are determined. Interestingly, in addition to achievement, points are also given for consistency and for improvement in HCAHPS scores. And this is a feature that's designed to try to mitigate the harm done to disadvantaged hospitals that may have a hard time reaching higher scores based on resource constraints. But despite those adjustments, linear mean scores for most categories are still notably higher in communities that have a higher proportion of white patients. So for example, you can see here that in communities that are 75% white or more, the likelihood to recommend the hospital is 88.5%, whereas in communities that are 25% white or less, the likelihood to recommend is only 83.4%. And this pattern also holds for nurse communication and care transition, which we will show later on are 2 of the most important categories for predicting overall patient experience. So we can also look at the same question in a slightly different way. On this slide, you can see percent white on the x-axis and the average recommend hospital linear mean score on the y-axis. And remember that in this case, percent white refers to the demographics of the zip code in which the hospital is located. This scatter plot and simple linear regression shows that there is a positive correlation between the whiteness of a community and the likelihood to recommend hospital linear mean score. The R-squared value is almost 0.1, which suggests that 10% of the variation in the recommend hospital linear mean score can be explained by the variation in percent whiteness of the community. Interestingly, as we were looking into differences in patient experience scores, we also found that there is not a significant correlation between HCAHPS linear mean scores and the quality of care being delivered, as measured here by the PSI-90 composite score in the complication and death file. You can see our multiple linear regression here that includes those scores as independent variables, as well as some basic demographic information about hospitals, such as the median income of their zip code and whether or not it's in a metropolitan area. And given that this model has a very low predictive value, we concluded that patient experience scores can't reliably indicate whether the hospital is good or bad according to this particular measure. And that led us to believe that hospitals with low likelihood to recommend scores are not necessarily poor performing hospitals in every case, but more likely they're just under-resourced, which leads to things like higher patient to staff ratios, less time for communication, less facility upgrades, and things like that that might be having an impact on patient experience. And if we systematically withhold payments from under-resourced hospitals, we could increase pre-existing disparities. So once we started looking into this issue, we found that research does suggest that the value-based purchasing program disproportionately harms certain hospitals. So one recent study found that hospitals with a higher proportion of Black patients receive more penalties from this program and less bonuses than other hospitals. So you can see on the top, 56% of those hospitals with a high proportion of Black payments are receiving, or patients are receiving a penalty, whereas only 41% of other hospitals are receiving a penalty. And on a similar note, a separate study did an analysis looking at safety net hospitals and found that safety net hospitals are also more likely to receive a penalty and less likely to receive a bonus relative to all other hospitals. So this all kind of makes sense when you think about the cycle that's created by payments tied to patient experience scores. Due to these low scores, disadvantaged hospitals receive less money through the value-based purchasing program, which means they have less money to spend on things like QI projects, staffing, facility upgrades, and in turn, these hospitals score lower on patient experience measures, which are then used to calculate their incentive payments, and then the cycle, of course, starts over with less money flowing into disadvantaged hospitals. And it's not just this program, there are other programs as well, and things like payer mix. But the point is there's a lot of cycles of disadvantage that are perpetuated if we aren't really careful in examining them. So now I'm gonna pass it back to Alex to talk about our recommendations based on what we learned through this analysis.
All right, we're going to share our recommendations for hospitals, for health plans, and then for policymakers as well. And so we'll start with our recommendations for hospitals. So given that the design of this value-based incentive program or the programs are not in the control of the individual hospitals, but they do still impact the overall hospital revenue, we first wanted to look at what the key drivers of the overall hospital recommendation score were to learn what the most important factors are and where hospitals should focus their efforts to improve these scores. So as you can see here, the multiple linear regression that includes both HCAHPS linear mean scores and hospital features has pretty strong predictive value with an R-squared of over 80%. All of the statistically significant p-values are highlighted here, but we determined based on their coefficients that the most important factors are geography as well as care transitions and nurse communication. So based on our analysis, we recommend with their limited resources, hospitals should focus on these high yield categories. To improve nursing communication scores, we recommend finding ways to free up more nursing time, such as decreasing patient to nurse ratios or reducing medical charting burdens. To promote seamless care transitions, we recommend promoting open communication with patients and caregivers about new responsibilities and challenges they may face at home after discharge. Examples of this might include medication education, mobility restriction, clarifications, diet modifications, et cetera, as many other examples. And finally, for hospitals that are, not currently meeting CMS interoperability standards, we recommend making this a priority because our model demonstrated that hospitals that meet this criteria have a higher overall patient experience scores. Improving interoperability will also improve care transitions, like we talked about above, by making it easier to share relevant patient information between different sites of care. While there may be financial and logistical challenges to meeting this CMS criteria, doing so would be an easily measurable goal. Next, we will move into recommendations for payers and policymakers who have influence over the actual design of these value-based programs. For ideas how to improve equity in value-based programs, we looked at the other CMS value-based programs and their equity impact. On the slide here is an overview of the 4 different programs that impact hospital payments. The Inpatient Quality Reporting Program is designed to incentivize public reporting of quality data, and these other 3 programs are all designed to link Medicare payment to quality. The Inpatient Quality Reporting Program does not have a notable equity impact, as most hospitals are complying at this point. However, both the Hospital Readmission Reduction Program and the Hospital Acquired Condition Reduction Program have been shown to disproportionately penalize disadvantaged hospitals, such as safety net hospitals. In response, policymakers have altered the Hospital Readmission Program to stratify hospitals based on the proportion of patients that they care for who are dual eligible for Medicaid and Medicare. This was intended to ensure that hospitals were only being compared against hospitals with very similar patient mixes. However, both the Hospital Readmission Reduction Program and the Hospital Acquired Condition Reduction Program have been shown to disproportionately penalize disadvantaged hospitals such as safety net hospitals. So this alteration that we talked about was successful in reducing readmission penalties for safety net hospitals by over $20 million per year. And the Hospital Acquired Condition Program is not currently stratified based on this dual eligible population or adjusted in any other way for social risk at the moment. A recent analysis did show that the same stratification method would decrease penalties to safety net hospitals by over $30 million per year. And it would decrease penalties for hospitals that care for the most patients from racial and ethnic minority backgrounds. So with this in mind, all payers should prioritize equity in value-based care program design. As we continue the transition from healthcare system based on fee-for-service to one based on value of care delivered, it will be essential to ensure that the programs and incentives in place do not harm hospitals that are serving disadvantaged populations. So as we think about recommendations for private health plans, they should design quality incentive programs or payment models that adjust for race and income of surrounding communities to ensure that certain hospitals are not being disproportionately harmed. They should also continually monitor the outcomes of their payment models and adjust as needed to improve the equity of them. For federal policymakers, we believe they should adjust the value-based purchasing program to account for this income level and race of the payer mix or the surrounding community. On top of that, policymakers should focus on adjusting payments payments and incentives, rather than on adjusting the actual scores. As many articles have pointed out, that adjusting the scores normalizes the concept that low-income and minority-serving hospitals will always have worse quality and worse experience scores. Instead, we should be clear with the data and then adjust the payments accordingly, because the goal is to distribute funds more equitably across hospitals. Thank you for listening to our presentation, and we'll take any questions you have now.
Wonderful. Thanks so much, Emily and Alex. Judges, this is our last team. So
would you mind one moment going back to the slide where you showed the unpredictability? Was this 2 slides up? I wanted to see that one more time. If you could, oh, one up. There we go. There we go. So why don't you have p-values of 0?
So those are just really, really small, and I'm trying to figure out how to include them on this slide. I had to sort of make those a little bit bigger, but they're all things like 0.0001 or something like that. Okay. Thank you. And same with the median household income. That says 0, but that is $5. It was a median income, so there is a coefficient there, and if you multiply it by 10,000 or something, you can start to see the value of that a little bit more.
Got it.
Right. Are there other questions? By the way, Emily, I hear what I usually do is I just do p is less than 0.001. That's how I write it. Or in like household income stuff, I just multiply it by 1,000, so you can represent in $10,000 or something, so you can get the coefficients in.
Thank you. Yes, that's helpful.
Well, if there are no other questions, I just want to congratulate, first of all, I want to congratulate all 75 presenters for just being just fabulous projects that they have submitted. I was not part of the judging, but I kind of scrolled through the executive summaries at the end. I mean, just an idea after another idea. And as you can see, the top 5 teams here as well, just very different approaches. I love that interdisciplinary perspectives that you bring. And now it is up to our judges, the final round judges, to decide the top 3 winners, the top 3 prizes. So what we will do is we will end our call, end our meeting right now. Our judges have a separate link, and I know that technically we were going to start at 6:30, but if you don't mind, Danita, David, Rich, and Mark, that Kim has adjusted that time so we can actually start right away and meet at the deliberation room. So we invite our judges, and we thank all of you again for participating. We thank all our judges, first round and second round, and our sponsors for making this happen. And really, it's this kind of projects coming from the students at TU that make it just so worthwhile for every effort that we put in creating an environment and engaging events like this. Thank you so much again, and have a great afternoon, and good luck to all of you.